Welcome to Patients at Risk. Today, I am talking with Dr. Anu Shukla. She's an internal medicine physician, and that she wanted to share a personal experience and why she is so passionate about physician-led care.
I'm a PCP in the greater Seattle area. I moved from India, so I'm a foreign medical graduate physician. So graduated from medical school in 2014. However, since the age of 18, I've been a doctor. We start early in India. So although I'm young, but I've been in medicine for a long time. So we do not have advanced practice providers or NPs in India. So that's a very big difference. So for me, it was quite of an adjustment to see non-medical school trained practitioners practicing side to side. Being an immigrant, you sort of adjust to everything in a new country. Everything is new. So you start with an open mind and you accept things are different and it is okay. You don't question them. So really residency was the first time that I was working with them inpatient and sometimes in critical care settings. So that context of accepting however things are was with me. Also personality-wise, I was a little submissive, as in, don't challenge them, put your head down. This is how it works here. Don't question it. You know that little voice in your head that tells you it's not right? You see things here and there and you feel that, oh my gosh, and you ignore it. You say, I'm a resident. I got to get things done. I cannot worry about this when it's happening to other people, like other patients. But then something happened to me. And that's where it became quite clear where my position was, like what I thought about this practice of medicine. So in my second year of residency, I was pregnant and delivered my child. I wasn't intending to deliver my son at the hospital I was training at, but so happened. So I was working up until I was right to when I got admitted at the hospital. I was completing my shift. I was in the hematology, oncology, and patient rotation. I was working with an NP. I did think that this NP had a lot of room to improve. I mean, I wasn't sure if she was well equipped to be treating the sickest patients in the inpatient setting. And now, with my son's delivery, there were complications, unexpected. It was healthy pregnancy until things happened. So I was assigned to midwives because I was low risk pregnancy. And of course, complications had to happen. But I think what really hit me was the moment that I woke up and my son got quite sick. He was almost being transported to NICU, but turned the corner um, around at the nighttime. And I woke up to the same NP that was working with me in the oncology inpatient setting as pediatrician. That paper had her name as my son's pediatrician. And she was the one responded to the code that was called rapid response that was called on my son. And that was the moment, fear just ran down my spine. And I said, oh my gosh, this person was just an adult oncology NP before. Even then, she had no idea what she was doing. Today, suddenly, she's transitioned to pediatrics. And she's the only person taking care of my son. I knew I had more medical knowledge than she did that day. So that was really that little moment in time. And I knew this is the worst thing on the planet. If I cannot let this happen to my son, I cannot let this happen to any other patient I care about.
And I'm assuming this is at a teaching hospital then. This is where you were in your training. So one assumes as a patient that if you're at a teaching institution, an academic hospital setting, that you are going to get the best doctors, the best care. And instead, your baby was cared for by a nurse practitioner when your baby was, by the way, acutely ill, who just that very same day or that week was working in an adult blood and cancer specialty clinic. That just boggles my mind.
So even then I dismissed it, right? That's how you keep going because you're working in corporate models of care. You have to work alongside. And New York was more regulated than where I am right now in Washington State, where NPs are independent. Every now and then I get in ethical scenarios with my patient where I have to stop and ask that question, like, which side am I on? Because there are two truths which are very controversial. It is true there are less doctors, more and more patients, and we need more people to take care of our patients. So that's a truth, and we have to solve that problem. But is solving that problem through expanding nurse practitioner program the answer? That I don't know. So that memory, that when things were crystal clear to me, is what I fall back to. And I say, if I cannot let this thing happen to my family member, I cannot let this happen to someone else. I did not escalate things mainly because I was in training. Felt very disempowered to even voice that concern. And in fact, today is the safest place where I'm actually talking about this outside of my own head. Now that I am 4 years out of training and I'm an adult attending, I can talk about these problems that in retrospect, um, but residents in training, we don't have any power. I cannot ask questions. I cannot, as a patient, again, cannot be fighting against or questioning the systems in place at a hospital that is supposed to graduate me.
I sometimes hear people say this is a turf war, but as you're talking about this, tears are in your eyes. You have become so emotional, and of course this was your baby, but when I saw you got the most emotional was just talking about the fact that these are patients and patient lives, and this is not fair, this is not just, and this is not right. This is not a turf battle. This is about making sure that patients have access to high quality care.
Correct. Yes, it is not about ego. We respect people and individuals. They can be smart people who turn out to be nurses and then progress to nurse practitioners. This is not about individual intelligence. This is about the sequence of training which we value and which is what caused that fear that day in my body. Now I had a visceral reaction to this person just does not know. They could be well-meaning. They would want to help kids and they are there that night trying to help somebody. So the intention is good and I respect them for that. But training exists for a reason.
It does give you a visceral reaction when you think about this, but this is the world that we're living in, and we are being silenced. Like, it is only now that you feel that you can speak about it because really you felt that you could potentially be affected, like your career, if you spoke out at that time about your concerns.
Correct. And that's what our training is as a doctor, right? We do our medical science studying part in medical school, then 3 or 4 years or however long surgical residencies are. We are just honing on those skills, more applications. And even after that training, you question yourself. You tell the patient, hey, I could be wrong. Come back to me if I'm wrong. That's what we do every day. That's what people don't understand. Medicine is not exact science. Nobody knows. We are making a best educated, really educated estimate of a probability situation where we're trying to figure out what the problem is and then trying to treat it. Nursing diagnosis or nursing practices are quite the opposite. It's the Dr. House game where you treat symptoms and you sort of do not care about diagnosis. That really is a very uncomfortable position for me to be looking. Medicine from that perspective is full of errors and harm. The other word that really irritates me now is access. Because when corporate talks about this problem, they're looking at, we want patients to be seen, we want to expand access. But in my mind, you're expanding access to harm. Not all medical care is medical care. I see that every day. I'm a primary care physician. Many of my patients who get viral infections can wait 2 days to see me in the opening I have. I also recognize physicians can also fall into the statistical probability. Clinical reasoning is complex. Anybody can make mistakes. But the odds of making mistakes or having a medical error significantly increases when you decrease that expertise, decrease the knowledge in the context of the situation changes when, physicians, however smart they are, they'll acknowledge that, they could be wrong. I've seen a trend in nursing practices where the pattern recognition or the algorithmic style of learning is so strong that the willingness to consider an alternate diagnosis or an alternate explanation of symptoms is just not there. And those are some basic core foundations of how learning is structured. And that's why we fall back to training, how training is different. You have to see the same common things in manifest in uncommon ways to really differentiate between complicated. Even things such as UTI, how we're asked to delegate UTI, simple visits to NPs or APPs. And in my head, I'm thinking, well, I've seen UTI present as like gynecological cancers, urological cancers. And in my mind, nothing is simple. That's why we have the job we have.
Yeah, you're exactly right. When I think about access, you make a couple of really important points. One, there is a large study by the Lancet from 2000 and I believe 19 that showed that more patients die worldwide due to poor quality care than die due to lack of access to care entirely. And that's something that I think is not being considered carefully when we look at expanding practice to non physicians in the name of access, that actually we may be harming more patients than helping. Secondly, you make the excellent point that there is something to be said for watchful waiting, and not everything requires an urgent trip to be evaluated. And I almost wonder if a better strategy would be to go back to a triage system. One of the things that's so great about a well-trained nurse is the ability to triage and to stratify who needs to be seen right away. And I think that's something that we've maybe gotten away from. Instead, it's just patients are to make their own determination about when they need to be or want to be seen. And I wonder if that's something that would make a difference if we want return to that model.
I 100% agree. An experienced nurse is much better of an assessor of a clinical situation than NPs who have never touched patients. I work with people who've been straight out of one online program to another online program and have never clinically assessed somebody. And our nurses are super smart. I trust nurses more than nurse practitioners. And I think from an NP perspective, those are well meaning people, but they themselves get put in very tricky scenarios. They have to navigate. The lack of training is just the universal truth. The training is deficient. And now they have to work as much, sometimes more, than people with better training. And then, have the similar expectations from patients regarding answering questions. It falls back to the very same concept that the training is so, so different. And the approach of training is so different that it cannot be used or extrapolated to different scenarios. And the other one that I worry about with nurse practitioners is they are diluting their pool. If you're just making more and more of similar skill level, it's just like expanding nursing program just a little bit more. So you have no filter as to who can be a nurse practitioner. There is no value in this huge, however many nurse practitioners there are. You're diluting your own quality. Why would a hospital system pay you more when they could just hire somebody for much cheaper? So I think ethical nurse practitioners would agree with physicians in actually making sure the quality is retained.
I think the problem is more the lobbying organizations and the educational organizations that have pushed to increase the number of nurse practitioners and expand their practice rights. You're right, the number of NPs has grown exponentially. In 2000, there were 80,000. And then this year, 24 years later, there are 380,000. So it's like a quadrupling in 20 years. At that same time, the physician growth has only been about 3%. So we hear a lot about this physician shortage, and yet there hasn't really been any effort put into increasing the number of physicians. Instead, there's been a lot of government policy geared towards increasing the number of NPs. And I think now we're seeing the consequence of a rapid expansion in a profession that was really intended to be a physician extender, to work under physicians and carefully with physicians. And studies show that that model works. But there are no studies showing safety or efficacy when non-physicians are working independently without physician supervision, and especially when they're taking care of typical patients, which means regular high-risk patients. All the studies ever done remove high-risk patients. So we don't really know from studies what those results will be, but we do know anecdotally, like in the cases that you've referenced, that you've seen, where patients are not getting the best care and they are potentially being harmed.
I think this whole concept of not giving importance to diagnosis and more to refills, standardization, I think that itself is so flawed in the attempts to scale healthcare systems or healthcare delivery, we try to replicate this, which is something which is not an exact science. It is not a Starbucks recipe that you can like hand out to everybody else or put in UpToDate or another app to replicate. I think that's where the logical fallacy is, and which is why we see corporate models fail. And this entire concept of scaling care through NPs is based on that same concept. There's an algorithm. Patient comes in with a complaint. Patients are themselves calling the diagnosis at the check-in. You just follow that anchoring 101. You fall into the trap of missing. You're setting yourself up. There's so much data. And the science and the practice of medicine, whoever practiced medicine will tell you this is not how diagnosis works. But we're scaling that error-prone model to 100%. So we're scaling problems, not the solutions, and we're calling it access. So anchoring is getting fixated to the first idea or first in the clinician's mind, a diagnosis. Often with sometimes patient comes in and says, I have anxiety, and you just anchor or fixate yourself to that diagnosis and do not think of differentials. Differentials is our magic. This is where physicians thrive, the thinking ones, the cognitive specialties. That's our magic. We force ourselves to think of what if this is wrong? What else could happen? Is there something else that could happen that could kill the patient? So that is what we train in. Our entire decade-year-old training is making sure we do not miss the what-if scenarios. But people who anchor, usually non-physician practitioners, are more prone to anchoring because the breadth of thinking of alternate diagnosis just does not exist due to lack of training. So you'll fall into the bias of or cognitive shortcut of attaching your thoughts to what the patient said. That this is anxiety, I'll give you an anxiety medicine. Well, a lot of things, including heart attack and stroke, present as anxiety. Any clinician knows that. This is what we are trained. Day one, intern, you know that. You're not anchoring or fixating on what the patient diagnoses themselves with. You have to consider that, accept it. You do not have to dismiss a patient's concern, but also think about it's your job and duty to think about the other things they have no knowledge of. And one could argue anchoring could happen to physicians, which is true. But our entire training is based on decreasing the probability of that. That's why we do residency, just stay in the hospital more than 80 hours a week, doing this thing over and over again, under supervision, under rigorous supervision. So we really, I would say objectively, we could study this. You and I could partner and study how, you decrease anchoring as you progress through your training. But in the case of nurse practitioners, well-meaning nurse practitioners, because you haven't been supervised and haven't gone through the breadth of training, it is impossible to change the probability of anchoring in that model of training. There is a place for nurse practitioners, like we were talking about, that there are less physicians, more patients, but the model of care is not through independent practice. It is through collaborative, not in the ways it's named collaborative in theory, but not in practice. We do have to, as a society, we have to come up with a solution, which is not this. Whatever is there right now is not working. We're seeing harm over and over again, and we do have to call out the problem. Only then we can solve it. And when we take, make it at the individual level about individual people, it's not good. People are well-meaning. Whoever is in healthcare in these times is wanting to do the right thing, including nurse practitioners. We're all on the same page trying to help people. I think where things get lost is the training part, because it's not their fault. They do not know what they do not know. But physicians do. We know how much of work, how much of studying it took for us to read that Robinson's Pathology of Medicine, Harrison's Internal Disease. It's impossible for a human. There could be a super smart NP with the IQ that surpasses Albert Einstein, but I cannot imagine them doing that studying in 6 months. So that is just a fact that you cannot change. And then there's the fact. So the training fact cannot be changed. When people argue in the training, it just is like, there's no point in that. It's crystal clear that the training is very different. So let's start from there. The fact, like sun rises from the east, the training is vastly different. I also agree that there are a lot more patients, less doctors. So the answer is somewhere in between, and people are not evil people. I think if NPs ever had an idea that the amount of training physicians do and the fraction of training that NPs do, and even the recent NPs who are only doing online programs without ever touching patients, I think any ethical person would not practice medicine in that scenario. I
Right.
just believe they have no idea what they're getting themselves into. It is sad. Every day I come across scenarios and I could go on and on endlessly about the problems we solve. It adds to the burnout and the work. There are already less physicians. Now you task them to troubleshooting. Uncomplicated, like my uncomplicated pregnancy became complicated. I can definitely attribute it to some misdoings on the part of, the people who were not equipped to be treating me. So you turn out normal things, normal problems into complications, and then physicians end up doing more work. So I'm not sure in the grand scheme of things you're helping doctors. Are you adding to their burnout, increasing patient access, or increasing patients' access to harm? These all magic words, I think we should really take a step back and look at it. Our intent was good. We started out somewhere, but we're not ending up there. We're ending up somewhere else. So what's going on?
Thank you again to my guest, Dr. Anu Shukla, for joining me. I hope you enjoyed this podcast. If you have and you'd like to learn more, then please get the books Patients at Risk and Imposter Doctors. They're available at Amazon and at barnesandnoble.com. And if you're a physician and you'd like to learn more about our mission, which is advocating for physician-led care for all patients and truth and transparency among healthcare practitioners, then please join our group. You can officially support us at our website, physiciansforpatientprotection.org. Thanks so much, and we'll see you on the next episode.